I know. So there was a request for 911 tapes, call, and info from Traub Lieberman LLP. They will be sent a memo stating that REMAC REMSCO does not maintain any patient care records. We've received ALS renewal applications from North Shore Ambulance, from NYU Hospitals, from Wyckoff Heights Medical Center, Ambulance Service, and we've also, guys, we actually need the quorum still. We also have notification of completed protocol update from Glen Oaks Volunteer Ambulance Corps and a request of extension for primary care ambulance. 1 month was granted. Okay, that's the correspondence. All right, next, subcommittee reports. So let me start with the executive committee report, which is really short, but there is one action item we need to take. The executive committee met, I think, 2 or 3 times over the summer to discuss some specific issues related to the drug shortages. One of the things that was decided on at the executive committee was an immediate protocol change for the asystole protocol in ALS to change, instead of an amp of D50 being given to every patient in cardiac arrest, to require a finger stick and only give dextrose to patients who have a sugar less than 60. That was passed as an emergency change over the summer because of the shortage and because there was such a limit of the amount of D50 available. Because the executive committee voted on it, that now comes as a seconded motion to this body as to whether or not we want to maintain the protocol like that or change it back and revert back, pending the shortage, revert back to the normal protocol that we had. Does that make sense? All right, any discussion on that change? Yes, David?
Yeah, I would like to make a motion that once the shortage is over, that we revert back to the original protocol.
So the motion on the table, because we can't have a second motion, is that we made the change. No, the motion is the new protocol that went into effect. We can vote that down, in which case, after the change, it'll go back to the old one, or we can leave it as is. And we can vote for it, and it will continue that way. But we can't have a second motion when there's a seconded motion on the table.
But can you combine it? Can you amend the first motion to say as long as the shortage is in effect?
So you can make a motion to amend the motion, but that's what essentially would happen. Right now, as the shortage is in effect, the protocol would stand as is. However, when the shortage is resolved and there is a plethora of D50, if we decide to vote against that change, as soon as the shortage is over, we would revert back to the old protocol. If we vote for it, we will be continuing the protocol as is after the shortage is over.
But if you plan to do the former, wouldn't you have to set that up ahead of time, because the shortage could be over and it could be a month before there's another meeting?
Well, no, that's why we're voting now.
No, I'm saying to set up so that it reverts back to the...
That's what the vote is for now. If we vote for it, it continues going forward. Meaning...
Until the end of the shortage?
No, it continues going forward beyond the shortage.
But what I'm saying is that if the shortage ends
tomorrow,
it's going to be 30 days.
If we vote today, it will revert back to the old protocol.
We have someone from Harvard, so we're good.
I'd like to make a subsidiary motion.
Great.
I'd like to make a subsidiary motion that we postpone definitely the question until the shortage is over.
That's a good idea. No, he's right. That's a good idea.
Well, okay, so that is, I'd have to secondary. So the answer is...
I second that. Subsidiary motion.
Okay, hold on.
I just second the subsidiary motion.
Can you stop for a second? All right, right now, the executive committee voted to approve this change. So now we have to vote as the whole committee, because the executive committee can only do things in between meetings, but eventually it's this committee that makes those decisions. So this committee now has to vote whether we want that or not. Yes, Dave.
before we vote, I just would like to bring to everyone's attention that our fire department data that has been recently rechecked shows that giving dextrose even to patients who are not hypoglycemic and do not have a history of diabetes improves ROSC. That's return of spontaneous circulation. Okay. We don't have data. We don't have data about. I'm sorry.
You wouldn't know that because you didn't have a finger stick to know that. I mean, you know that anybody
we did compare the data before and after giving dextrose. Okay, and we do have data about whether they're diabetic or not.
You know what the sugar was?
We don't have the finger sticks.
Right, so you can't make that comment.
So, okay, I stand corrected. So our data shows that, and we recently checked it on 2016 data, after we had it on 2009 data, that for patients, whether they have a history of diabetes or not, if we give them D50, it improves ROSC. It has nothing to do with outcomes, with with hospital discharge home outcomes or anything like that. We do not know that. That's very hard to obtain. But in order to go home with a good CPC score, you first have to obtain ROSC.
True.
So that's where the extent of our data.
That's supported in the literature as well. In addition to the fire department data, that position is supported in the literature.
Peter.
Yeah, I'm losing the thread here, but actually the literature does not support using ROSC as a decision-making outcome. As many interventions cause harm that produce ROSC as the other way around. Furthermore, ROSC is not necessarily a good outcome, particularly if you don't survive. The other thing is that the data that we're capable of generating within this system is totally incapable of generating an inference that this is improving outcomes. You may simply be showing that the process of selecting patients for this intervention is what's responsible for the apparent better outcomes. You're selecting the patients that you think are going to do better. You give them more. You do this. You cannot possibly draw an inference of efficacy from the kind of data that we can generate here. You need a randomized trial.
This is data that we can obtain with the. We all know that EMS research is very limited and very difficult to obtain data.
I'm not blaming you, but you cannot
One second.
Let me just respond, please.
I am implying an association, not a causation. And there's a big difference between the two. Okay? And that association exists, and whether ROSC is a good outcome or not, I again say what I just said. In order to go home with a good CPC score, you first have to start with ROSC. Whether it's good or not, that's what we have. That's the data that we have.
Okay. Any other comments? Yes.
I was forwarded another article, I think they sent it about ALS not being good cardiac arrest. I mean, the study that shows we're looking at epi now. You get better ROSC, but ultimately poor neurologic outcome and higher rates of death. But David is right. I tell my medics as well. You have to have a ROSC to have a chance of survival. But now, whether that's good or not seems to be a question. I mean, at some point, I think they took out atropine, right? We might go to a BLS cold type for BLS with a defibrillator.
Okay. Listen. I hear that.
Just
hold on 1 second.
Just summarize.
1 second, please, guys. I understand that there's a lot of controversy whether ALS is beneficial in cardiac arrest, and I understand that the literature doesn't always support it, and it's gray at best. But the question on the table, the motion on the table is the executive committee made a decision to change our protocol so that in PEA arrests, you check a finger stick prior to giving D50. If it is below 60, you give D50. If it is above 60, you don't. That's what is the protocol today, and that will remain the protocol if we agree that that's what it should be. If we think that it's not the best practice and that after the drug shortage, it should go back to just give a dose of D50, that's fine. But that's what's on the table right now. So let's focus our discussion on that, please.
So my point is simply that we should be voting on the basis of the pragmatic issue before us that was generated by the drug shortage, and not try to emboss it with inferences of this is actually improving outcomes. It's a practical issue. There's a drug shortage. That's why this issue is there in the first place. Forget the other stuff. Deal with the pragmatic issue.
All right, seeing no further discussion, we will vote, and the vote is on. If you vote in favor, it is to keep the protocol as it is today, which is you check your sugar. If it's below 60, you give D50. If it's above 60, you don't. And that will remain after the drug shortage is over. If you vote against it, it will revert back. When the drug shortage is over, it will revert back to the old protocol, which is to give D50 to everybody.
But so
That's
far
what we're
as the
voting on.
drug shortage exists, it will,
It's going to stay as is, which is what we have now. But this way, like Neil was saying, if the drug shortage ends between meetings, the protocol would change. Anyways,
Yeah, I didn't understand exactly the way the resolution was
There you
set
go.
up.
So I
But
just
what you said
clarified it.
makes perfect sense, and that's something that I can see.
okay, so roll call vote, please.
Yes, sir.
Chuck, can you clarify, please?
Sure. The motion that we're voting on right now, if you vote in favor of the motion, you're voting that the protocol change, which went into effect emergently, will remain after the drug shortage, which is that if you check your finger stick, if the sugar is below 60, you give D50. If it's above 60, you don't. If you vote against it, then as soon as the drug shortage is over, we will revert back to the original protocol, which was that everyone, regardless of their finger stick, gets an amp of D50. Is that clear? Okay. Go.
Saving for last. Christopher Graziano,
Against.
Kevin Munjal,
Against.
Cindy Basilos,
Against.
Glenn Aceda,
For.
Brad, Nathan Briesman,
No. Against, right?
Against.
Jeffrey Rabridge,
Yes.
yes. Dr. Floenbaum,
Against.
Dr. Marshall,
Yes.
Dr. Redlener,
Against.
Dr. Wire,
For.
Dr. Barbara,
Against.
Dr. Benelli,
against.
Celia Quinn,
Against.
Dr. Martinez,
For.
Dr. Bowe,
I abstain, I'm for Northam.
Dr. Fisher? I'm sorry? Against? Dr. Krupi?
Yes.
Dr. Van Voorhees?
Abstain.
Welcome to Narcan. One, two, three, four, five, six, seven, 8, 9, 10, 11. Pretty sure it's carried. Count. 1, 2, 3, 4, 5. Yes.
So the motion did not carry. When this drug shortage is over, we will revert back to the original protocol.
At which time it could be reconsidered on the merit of the scientific evidence.
Well, if we wanted to make a protocol change, it would have to go through the process that we discussed and on a regular protocol cycle.
And go into effect on January 1st.
Okay. All right. I'd like to go home tonight, guys. So let's, medical standards subcommittee report, please.
Which one of them?
one from today.
No, how about June?
Yes, both.
Oh, man. So I'm trying to look at the minutes from June and hopefully we'll review everything. So we discussed a lot about drug shortages then.
Just focus on any action items. You
I'm
don't have
trying
to
to.
do the nuts and bolts.
I think we said we discussed it. A lot of protocol changes that were actually brought into effect. CPAP for BLS providers. Medical standards, this was approved by medical standards.
It was approved at CMAC.
I'm sorry?
It was approved,
It was approved
and
at
it's
CMAC.
already in our.
Yeah, but it needs to be approved by REMAC. So this is brought from medical standards to the second motion to REMAC.
But it was approved.
No,
It wasn't. But as
Because
soon
there
as
was
you
no
say
quorum.
yes tonight, then I can
No.
act.
Oh, I got you, okay. So all in favor of allowing,
this is a protocol change.
Yeah, yeah.
yes, so this is a roll call vote. This is a roll call vote for all in favor of allowing BLS to use CPAP, if approved by the medical director. It's not mandatory.
After discussion of the agency.
Right. Sorry, I'm just trying to keep some track.
That was BLS. No, I'm so sorry. Okay. Dr. Graziano?
Four.
Okay. Dr. Munjal?
Four.
Dr. Basilos?
Four.
Dr. Seda?
Yes.
Dr. Reisman?
Yes.
Dr. Rabbit?
Yes.
Dr. Blombaum?
Mr. Jefferson.
Oh, okay. Dr. Marshall?
Affirmative.
Good. Dr. Redlener?
Four.
Dr. Wire?
Yes.
Dr. Barbara?
Yes.
Dr. Benelli?
Yes.
Dr. Quinn? Yes. Dr. Martinez?
Yes.
Dr. Bove? Dr. Fisher? Dr. Krupi?
Yes.
Dr. Van Voorhees?
Yes.
Carries.
Excellent. Next, David.
Next, Appendix B. It was recommended that blood pressure estimation will be deleted, radial plus 80, so that radial pulse is about 80 systolic, femoral is about 70 systolic, cardiac is about 60 systolic. This BP estimation tool is part of EMT and paramedic curriculum. Dr. Barbara will provide literature to provide proposed revision. This will have to be presented to CMAC at a statewide
So
change.
is this coming for the motion?
And yes, medical standards also recommended approval. This will be should be brought to you.
I'm sorry, Joe, on the CPAC, when will that be effective?
That is effective as of September 1st. It was in the September 1st pending our meeting. The state already approved it.
We had met in June. We could have gotten it in.
You want the citation,
What's that?
the literature citation?
For this, no.
For this, no.
What I was just referring to.
Yes, you bought it, you got it?
I have it.
Next.
Definitely.
Anyone wants to review it?
So I just have to vote for this. A motion to remove to strike
The language.
the language about pressure per pulse
The way
location.
our EMTs are taught blood pressure here, radial pulse. It's still in the EMT curriculum, but our docs say it should be out. Okay. Ready?
Yeah, go ahead.
Dr. Winchell?
Yeah.
Dr. Graziano?
Take out the language for blood pressure.
Kevin Munjal?
Four.
Dr. Basilos?
Four.
Dr. Seda?
No.
Dr. Isaac, Dr. Reisman?
Yes.
Dr. Rabbit,
Yes.
Dr. Bloombaum, Dr. Marshall,
Yes.
Dr. Redletter,
Yes.
Dr. Wire,
Yes.
Dr. Barbara,
Yes.
Dr. Benelli,
Yes.
Dr. Quinn,
Yes.
Dr. Martinez,
Yes.
Dr. Bove, Dr. Fisher, Dr. Krupi,
Yes.
Dr. Van Boris.
Yes.
Excellent. Next,
There are no other action items for the June medical standards meeting.
let's go to action items from
Now
today.
let's go to action items from today. So, the Medical Standards Committee met right before this meeting.
Let's just go with action items.
We had a review about the progress of the stroke tag. We had a lengthy discussion about setting the dates, a new date, or an official one-time date, once-a-year date for protocol implementation. That date was approved as January 1st. That was of every year. So next time that will take effect is January 1st, 2019. We also approved that the protocols will be updated on an annual basis, once a year. And those are the two action items in that effect. So I think we should vote on those together. Oh yeah, we talked about publishing, that the protocols will be published after the fall season for implementation in January 1st.
Sure. Okay, so the motion on the table is to implement a January 1st implementation date for our protocols going forward. This will begin on January 1st, 2019. The protocols will be released for education immediately after the CMAC in the fall, which is either September or October. And the last protocol changes that will go to that meeting from us will be in June. Correct.
And an annual update.
Right. And that our protocols will be updated annually. All right, go ahead. We don't need a roll call, there's no change. So all in favor, please raise your hand.
One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 in favor.
Good. Anything else? Dr.
Yes.
Pinelli?
The FDNY submitted rescue task force protocols that were approved by medical standards, and the report is second in motion to REMAC for.
So for anybody who was not here for the last meeting, these are specifically to be used in the warm zone by specially trained rescue task force FDNY personnel using appropriate protective equipment and to basically limit them to performing necessary tasks in that area and not requiring them to provide the full BLS or ALS, as it is in the future, care in that area, which would be a danger to them. Any discussion on those protocols? All right, seeing none, we need a roll call vote for this.
Okay. Dr. Graziano,
Yes.
Dr. Munjal,
Yes.
Dr. Beselos,
Yes.
Dr. Sater,
Yes.
Dr. Reisman,
Yes.
Jeff Rabbit,
Yes.
Dr. Floenbaum,
Yes.
Dr. Marshall,
Yes.
Dr. Redletter,
Yes.
Dr. Wire,
I was gonna have left them.
Dr. Barbara,
Yes.
Dr. Benelli,
Affirmative.
Dr. Quinn?
Yes.
Dr. Martinez?
Yes.
Dr. Bove? Dr. Fisher?
Yes.
Dr. Krupi?
Yes.
Dr. Van Boris?
Yes.
That also carries.
Okay. Is that it, David?
There's one more motion that was brought to, that being brought to REMAC. There's a new formulation of Narcan, 4 milligrams in 1 ml. And there was again a discussion at medical standards, and the motion that's being brought forward is to approve both the current formulation and the new formulation at the discretion of the agency medical director.
Okay. Any discussion on that? Basically, there is a free version, which is 4 milligrams per 1.1 ml versus what we currently have, and that is going to be available to providers from REMSCO. So basically, our protocol will allow either formulation to be accepted.
But that's a change in the protocol because currently 2 milligrams is
Correct.
standard dose.
Correct. Before we vote on this, I just want to make one comment. We have a representative from HIDA here, which is a high-intensity drug trafficking program. It is a joint, it's a federal? It's a federal task force on tracking and monitoring high-intensity drug use. Grace does have a presentation or a little bit of it. She can talk a little bit about some of the drug mapping that they're doing. I know that it's getting late. Would it be okay if she does that at the end of this meeting, or would you rather, and she's agreed to come back to the next meeting and have that discussion? I feel like people are starting to fade. There's some business that we have to get through, but I want to give it the time that it deserves. So we're gonna vote on this, but again, I don't know if we want to maybe have this discussion about HIDA at the next meeting. I think that's a better idea. All right, so we're going to bring that up. I just want to thank her for coming, but let's go back to the vote. Yes.
I have just a question on this. So if the medical director can choose the formulation, either the 2 milligram dose or the 4 milligram dose, does that mean the medical director can decide the initial dose can either be 2 milligrams or 4 milligrams, regardless of which formulation?
No, but the protocol calls for 2 with a repeat of 2.
Hold on.
Right. So, but if
They
the
cannot.
formulation you choose is a 2 milligram formulation, you're giving 4. So,
Yeah, so that's all you'd be able to do.
right. But I guess the question is, if you have the 2 milligram formulation, could you say, well, since the other formulation allows me to give 4 at one time, you say we're going to give 4 with the 2?
No, it's actually written in the protocol very clearly. 1 milligram per ml in each nostril. If you choose this preparation, if you choose the other one, it's 0.4 one time, you're done. Or 4 milligrams, 0.1 one time, you're done.
Is this an emergency? Does
Sure.
anyone from New York City Poison Control Center have an opportunity to comment on that?
Yes.
Well, that was, yeah, David had mentioned that prior.
I missed it.
I sent an email with specific questions to Doctor, so I can share that with you if you'd like.
Just what was there?
They were not shared. They were not part of that decision. And quite honestly, we have not seen yet carfentanil overdoses in New York City. We have seen other synthetic opioid analog overdoses.
They like the small.
And Dr. Su did not feel that we need the higher dose.
They're not supporting the 4 milligram?
Not necessarily, no.
Okay, that's what I want to hear.
Right, yes, Dave.
So according to what we discussed, if this is approved, it will go into effect January 2019? Right?
No,
It's a
so this-
protocol change. Yes, it's not an emergency, according to what we just discussed earlier.
Well, I don't know if it's a protocol change or if it's just additional formulation. It's up to you.
But it is a protocol change.
So if we're saying it's a protocol change, then yes, it would have to wait. Unless we felt that there was a reason not to, but
If it's going to be done, it
we
should
don't
be
have any
done.
emergency. We haven't defined that yet, so.
If it's going to be done, it should be done as an emergency. By 2019.
Well, I don't know if it should be done as an emergency, or maybe a drug shortage type
By
of thing.
2019, there'll be an 8 milligram package.
So we're not accepting that.
No. That's what we're voting on right now, but Nathan asked an interesting question. If it's a protocol change, does it have to go to CMAC?
CMAC already.
They've already approved this.
So
They already
it's
approved the 4.
already approved to be done that way at the state.
They can use the state.
They-
It's not a protocol change, really, it's a